Thank you, JC. First of all, I would like to thank JC and Christina to have me here in this wonderful first course on chronic illness in children and adolescents. And I'm very honored to be able to give this presentation to you. So the session this morning was about practical issues, practical questions, how to start, what to do, what not to do. Now we can start thinking about how can the future looks like. We kind of know what we have today, but we will go a little bit more into details. But then the way is open. We have to see where can we go from here. The good thing of being the last presenter in a conference, in a course like this, is that we don't have to start from scratch. You already learned a lot, you already heard a lot, but certain things will come back in this presentation, and it won't hurt to have some repetition when it comes to really reminding certain things. So, in a presentation that JC was giving yesterday, he was referring to definitions of transition. And indeed, if you have a look in the literature, you will find numerous definitions, each with different characteristics. But the interesting thing is when you go closer into these definitions, you see some common grounds. You see some elements that are consistent and recurring in the different definitions. And therefore you can say in general, the common ground is that transitions are passages from one life phase, physical condition or social role, to another, and it results in a temporarily disconnectedness of the normal way of living. And therefore it demands an adjustment of the patient and the environment. Afaf Malaise, in her book on transition theory, she identified 4 types of transition: developmental transitions, situational transitions, health and illness transitions, and organizational transitions. The developmental transitions have to do with going from one stage in life to another stage in life. And you see here some examples. For instance, adolescence, parenthood, aging, all developmental transitions. Situational transitions more have to do with going from one setting to another, from one role to another. And here it is, for instance, changing educational or professional roles, starting in a new job, being retired, and this kind of transitions. The health and illness transition, most of us are healthcare professionals, so this has to do with adapting to certain health situations, adapting to chronic illness, returning home after hospital admission, recovering from surgery, and so on. And then finally, the organizational transitions. This is really at a macro level. This has to do with healthcare systems that are in transition. For instance, a lot of developing countries, they also have a healthcare system that is in transition. And then we are calling this organizational transitions. But of course, here we are talking about young people. Here we are talking about adolescents and about young people with a chronic condition. And we know from a lot of literature, a lot of studies, that young people don't differ that much in terms of the developmental tasks that they have to, that they are facing. They are experiencing exactly the same challenges in growing up than non-affected adolescents. But on top of this, they have additional concerns about what my future will bring. What about my health status? What about my prognosis? It's an extra burden for them. They are also at higher risk for prolonged dependency, developmental issues, or psychosocial delay. And you see, and of course it depends on the area you are looking at, but in certain areas you really see a delay in stepping into romantic relationships, getting married, starting a family, and this kind of things that are very normal developments in life. They also have changing healthcare needs and access to healthcare. It's easy when you have a pediatrician, but at a certain moment, yeah, maybe one day you become pregnant and then you need another kind of provider, and you develop comorbidities. Think about the session that the workshop that Grete was sharing yesterday about mental health comorbidities. This is also an additional challenge for a lot of these people. And then we know if there is one phase in life that people want to experiment, it's during adolescence. And actually, experimenting behaviors and peer pressure can be more detrimental in certain conditions. So this means that the challenging period that adolescence is in itself is really extra attached, with extra burden for these individuals. But this is not the only problem. We all know, and most of you are working in the pediatric field, indeed, when a child is a child, pediatric care is most appropriate. But when they are growing older, at a certain moment, pediatric care is not the most suitable and appropriate setting anymore. And then a transfer to adult services are really recommended. So going back to this scheme of malaise with the 4 types, we see that thinking about young persons with a chronic condition and thinking about transitions, the developmental transitions and the health and illness transitions are most prevalent. So we should bear this in mind, and we should take that into consideration. Coming back to definitions. If there is one thing you want to remember, or if there is only one thing you can remember from this presentation, it should be this slide. Because this has to do with the difference between transition and transfer. Transition is the process by which adolescents and young adults with chronic childhood illnesses are prepared to take charge of their lives and their health in adulthood. And if you compare this definition with the first definition that I showed you in the beginning of this presentation, you see that this is more an expression, more a definition in terms of a healthcare intervention. We need to prepare the people to be transferred and to take charge of their lives and health. And indeed, transfer defines an event or a series of events through which adolescents and young adults with chronic physical and medical conditions move their care from one setting to the other, from pediatrics to adult care environment. But indeed, the subtitle of this presentation was where to go from here. We have different ways we can go, but it's important that we start to look where we are today. What do we have? What do we know? And then we know what way to go. And to be honest, it's amazing if you see what is going on globally. And this is just a shot of what is happening in different places, but there are even more places, more centers that are really working on transition. And if you really want to know what is going on and how are things organized, there are numbers of websites, places where you can look at, go into the details. What is this program? What are the interventions? What are the outcomes? How do they do this? Who are the people involved? And so on. So a lot of resources are there. Don't reinvent the wheel. Try to use the resources and try to look what is applicable for you. You cannot just copy-paste because that wouldn't work. But look for what are the things that are working for you. Of course, as a researcher, you start to wonder like, okay, but what is the evidence that is underpinning everything? All the developments are great, all the experiences that are built up are great, but what is the evidence that is underpinning this? And most of you probably know that in research we have this, what is called the pyramid of evidence, the different levels of evidence. And it's like actually a kind of hierarchy of how strong a certain design is. And the higher in this pyramid, the stronger the design is considered, and therefore quite often using a higher ranked design results in more trustworthy findings. So already in 2008, quite a while ago, Deborah Hilderson, my then PhD student, she reviewed the literature at that time and categorized the papers that she found into the different levels of evidence. Level 4 has to do with editorials and expert opinions, case series and case reports, and she found that 53% of all the publications on transfer and transition could be categorized as level 4 evidence. Level 3 evidence are case control studies and cohort studies, 42%. So the big bulk of research or publications is level 4 or level 3, with all the limitations that this kind of research has. 5% could be categorized as level 2 evidence, and 0% could be categorized as level 1 evidence. I have to repeat, this was a review done in 2008. In the meantime, we know that some level 1 studies have been published. I will come to that later on. And I can also inform you that currently we are doing an update on this review. So this is called a scoping review that we are doing, and the protocol paper of the scoping review will be published very shortly in BMC Systematic Reviews. Okay, we know what the bulk of articles is about, but let's have a closer look on what is in, or what are certain aspects that are requiring our attention. And let's first have a look at the concept of transfer. Remember, going from one place to the other, going from pediatrics to adult care. What is the problem that we are facing there? It's the so-called care gaps, lapses of care, loss to follow-up. It all has to do, these are three terms that all have to do with discontinuity of care. And the first problem that we are encountering in that respect is that we don't have a uniform definition of these three terms. And maybe other terms are existing as well. And at the end you start wondering like, okay, how comparable are the things? What are you talking about when you say lapses of care? Or what do you mean when you say loss to follow-up? Is it temporarily? Is it more permanent? So that's kind of confusing. And if you ask me where to go from here, this is one thing we should solve. The scientific and clinical community should solve the issue of the definitions here. Second question, how big is this problem? What are the numbers we are talking about? Well, I was looking in the literature and tried to find data on loss to follow-up on care gaps in different conditions. Let's first look at diabetes. Several studies have been published so far with, of course, different proportions of loss to follow-up and care gaps. If we calculate a median on the care gaps, for diabetes, we found a median loss to follow-up proportion of 24%, which means that 1/4 of the diabetes patients, in general, over the different studies, is either gone permanently or temporarily. If you have a look at other endocrinology disorders, for instance, adrenal disorders, and you calculate a median proportion, you find 34% lapses of care. Rheumatic disorders, 41. Cardiac disorders, 42. So it's amazing to see how many patients are not receiving the care that they should receive, and mainly when they are in this transition period, mainly when they are assumed to go from pediatric setting to adult setting. So indeed there seems to be a gap where it is easily to fall in, and it's easily to get out of the picture and do not receive the care that is required. Looking at medians of lapses of care is one thing, but indeed if you look at the ranges, you really see the magnitude of the problems. In diabetes, one study has care gaps up to 43%, and in congenital heart disease there is one study up to 76%. It's huge if you imagine that 3/4 of the patients are gone. Yeah. So there really is a problem. Okay, then the question is, can we kind of predict this? Are there certain factors that make patients more vulnerable for this? And early 2016, Eva Goossens, one of my postdoctoral fellows, published a review, systematic review, looking at risk factors, non-categorical, so it was not specifically oriented to a certain condition. And she identified the following risk factors: living independently, male gender, lower family income, travel distance, so a larger travel distance to the clinic, milder disease severity, fewer pediatric outpatient visits in the pre-transfer period, a non-university hospital, childhood hospitalization, and missed appointments. These were all risk factors for which a consistent finding was found in the literature. So there were some variables where some was protective, the other was a risk factor, but for these variables it was consistently a risk for the patients. But of course there are also some preventative factors, certain factors that helps to stay in care. And these are the presence of comorbidity, apparently, a written referral, good early attenders, greater independence in attending appointments, perceived need for specialized care, self-efficacy, no substance use, and adherence to medication. Why is this review so important? Because it already gives you some potential targets for interventions. And let's have a closer look at this selection of factors. Fewer pediatric outpatient visits in the pre-transfer period as a risk factor. Written referral, good early attenders, greater independence, self-efficacy. These are things that are really the targets in transition programs. So to a certain extent, you can see that transition programs may be a solution to reduce the risk for care gaps. That's something you can infer from this. But it doesn't have to be transition programs alone. There is also some, what we call low-hanging fruit. For instance, look at missed appointments. There are interventions, there are low-cost and very easy interventions that can reduce the risk for missed appointments. And for instance, in our hospital, we started some years ago with an SMS reminder system. So 1 week before the outpatient clinic, it's a hospital information system, so it's not human people that are sending the text, so it's the system that is doing so. And what did we found? The missed appointment rate in the SMS group was 5.3%. If we compare this with the historical cohort of 2 years before, this was a period that we did not send any SMSs at all, it was 8% at that time. And if we compared it with a group that didn't have a smartphone or a mobile phone, or didn't give the mobile phone number to the hospital, so they could not receive an SMS reminder, there it was 12.6%. So you really see a difference when this SMS reminder system is used. Low cost, easy implementable, it is reducing missed appointments, and in its turn, for this vulnerable population, it is reducing lapses of care. So risk factors are really informative for us to see what are potential targets for interventions. But if you look at the different risk factors and preventative factors that I just showed, they are all at patient level. They are all factors, all characteristics of the patient. There are no studies that looked at hospital factors. Let's think about, is there a transition program available? Are there adult services that can take over the patients for this? Is there a transfer of medical files from pediatrics to adult care? How do people navigate in the hospital? Do they have to go to another building, or is it the same front door? And this kind of hospital factors may play a role, and there are no studies that have investigated that so far. The same is true for healthcare system factors. You can imagine that out-of-pocket expenses may play a role in care gaps. Is there a national guideline on transition? This may play a role. But again, we don't have any evidence on that whatsoever. So, what is the thing that we have to do? We need to undertake what is called multi-level studies. Multi-level studies where we have the first level, patient characteristics, we still need to include. But the second level are hospital factors, the examples that I just gave. And the third level are healthcare system factors. So by doing this kind of studies, we really can see what is the contribution of patient characteristics, what is the contribution of hospital characteristics and healthcare characteristics. And certain hospital characteristics, if we would find them, these are the targets at the hospital level. We need to work with our management to try to change that. Are there certain healthcare system factors? We need to work with policymakers to either change policy, or when there are some preventative factors, that we keep that. Yeah. So it's as I said, no study has done this so far. So we thought that it would be time to do so. And currently we are in the startup of what we call ADOLE 7C project, and it stands for Adolescents Receiving Continuous Care for Childhood Onset Chronic Condition. And here is the website if you are interested in this. This study, in fact, is a collaboration between Sweden and South Africa. I'm coming from Belgium, but I'm having a visiting professorship in Sweden, and I'm doing a lot of research there as well. We are working together with colleagues in South Africa, where we want to look at the factors at the 3 levels. We have a rather generic approach, but we start with congenital heart disease because this is what we know best, and this is, for practical reasons, also most accessible. We have the network of colleagues in South Africa as well. But from South African point of view, they said, well, don't look at congenital heart disease only, also look at rheumatic heart disease. Because this is in Europe almost a non-existing problem, but in South Africa it's still highly prevalent. And our hypothesis is with the current influx of refugees in Europe, this probably becomes a bigger problem. And if you know how many refugees have arrived in Sweden, it's huge. So in fact, we cannot neglect this. And this collaboration, both partners can learn. I mean, South Africa can learn from Sweden when it comes to adult congenital heart disease, because this is relatively in its infancy in South Africa. But on the other hand, they have a vast experience with rheumatic heart disease. And in Sweden, we can learn from them. So this is a great study. So in Sweden, we have 4 centers. Gothenburg, Lund, Stockholm, and Umeå. We are expanding this right now with Uppsala, potentially Örebro, and Linköping. Yeah. And then in South Africa, we have Cape Town and Port Elizabeth. Yeah, that's the idea. And then we have indeed different patients, different centers, different countries. If we would be able to expand it to more countries, this would be great. If we would be able to expand it to other conditions, this would be even greater. And this is in fact the ambition that we have with the Adamas 7C project. We have been addressing transfer so far. Now let's have a look at transition. And it becomes clear when we are talking about transition, transitional care, transition programs, this is a complex thing. And what do we mean with complex thing or complex intervention? There are different elements in this intervention, and it is always difficult to really pinpoint what is the active ingredient of this intervention. It's different with giving a new molecule, a new drug. But here there are different aspects. Is it the transition coordinator? Is it the accessibility? Is it the nice physician? Is it whatever plays a role? It's difficult to pinpoint. And therefore it's called a complex intervention. And from a research point of view, you would think, oh gosh, this is so complex, we better stay away. Well, the Medical Research Council in the UK already in the early 2000s, they developed a framework of assessing complex intervention. And in 2008, they published an update version. And in fact, this is how this evaluation and development and evaluation of complex intervention looks like. It's not a linear process, it's more an iterative process, and you can go forward and backward, and it's also kind of circular, so it will never stop. But in fact, this is really interesting to guide you to see how can we develop our intervention. And I would like to use this frame to go a little bit closer into the different aspects. So let's start with the developmental phase. Here you can read identifying the evidence-based, identifying or developing the theory, modeling process and outcomes. These are the 3 factors of the developmental phase. Identifying the evidence base. Remember the pyramid that I showed you in the beginning of this presentation. Indeed, 95% of the studies are level 3 or level 4. But still, it means that there is a lot of evidence. So we cannot neglect this. We should use this evidence as well. That's why these studies have been conducted. We can not only look at the top, and say we cannot use these studies. Try to use the evidence-based, and it is really a vast evidence-based. In 2008, Deborah Hilderson reviewed, at that time, or included 230-something articles. Now it will be much more, absolutely. Yeah. So that's one thing, evidence-based. Second part, identifying or developing a theory. If you ask me, this is a problem right now. Okay? There are some books, there are some documents that are called transition theory, but if you look at this, this is not really helpful for what we are doing here. This is not guiding us. And you could wonder, as a healthcare practitioner, we are doers. We want to fix things. We want to serve our patients and clients. And then the theory, why do we need this theory? Well, one of my former professors, he always said, there is nothing as practical as a good theory. And what he means is, like, a theory is guiding us. We can do what we think that we should do, but what do we, then we start educating patients. Remember the discussion that we had this morning. We are not necessarily doing the good things, of which we know that they are having an impact. We are not necessarily using a good model to make sure that one thing is linked to the other. So what we really could benefit of is having a sound transition theory when it comes to young persons with chronic conditions. This is not a task for clinicians. This is what researchers and program developers should take up. Yeah. Then modeling the process and the outcomes. Let me come to what JC yesterday called the story of frustration. When JC and Christina were doing this Delphi study, they were looking at key elements and indicators for successful transition. And JC used that term, what they had in mind was, we probably will come up with issues like, are the patients able to buy the tomatoes? Are these patients able to buy a ticket for a concert of Tina Turner and to manage to go there on their own? So, I mean, you start with certain expectations, but then this came out. What were the indicators that finally were retained? Patients not lost to follow-up, attending scheduled visits, patients building a trusting relationship with the adult provider, continuing attention for self-management, and so on. And to a certain extent, I can understand the frustration that is attached with getting these results if you expect the real transitional developmental things. On the other hand, I can see the point if we go back to the risk factors of transfer. Going to fewer pediatric outpatient visits, missed appointments, written referral. Remember, these were the things that are addressed in transition programs. So, if you look at transition programs and what you are doing in these transition programs, then it makes sense that it is connected with continuing care. But I fully agree that we should not only look at this, there are also other variables we could address. Thinking of knowledge, transition readiness, self-management, self-efficacy, empowerment, all variables that make sense in evaluation of transitional care. However, the key in this respect is the distinction between what is called distal and proximal outcomes. If you, for instance, say, being totally independent is my ultimate outcome, then it will take a while before you get there. Hence, if you take that as a parameter to evaluate the successes of your transition program, then it will take ages before you can demonstrate the value, because this is a very distal outcome. You have to take some more proximal outcomes. And even keeping patients in continuing care, it's pretty distal. But for instance, empowerment or self-efficacy, that's more proximal. And by empowering patients, by increasing their self-efficacy, you equip them with the tools, with the skills to navigate in the system, and then in its turn, you assume, you hope, you are trying to make people staying in the system. Yeah. So, very important to know the concept of the distal and the proximal outcomes. The question then is, how can we evolve from identifying the evidence-based, developing a theory, and modeling the processes and outcomes? Well, a very interesting methodology in that matter is the intervention mapping methodology. And people who followed the intervention mapping course are using this book. They call it the Bible of health promotion activities. This is really a sophisticated and very detailed way, a very detailed method of developing an intervention, starting from what do I want to achieve at the end, what is very distal, and then coming more proximal. What are the health issues right now? What do I want to change now? What are the risk factors for that? What are the determinants? And these determinants I can work on. And then you develop different strategies to work on the different predictors, the different determinants, and doing so, you are intervening in a very comprehensive way. So you are avoiding that you have one shot and hope that it is working. Here it is really a comprehensive approach. So intervention mapping, as far as I know, never has been used in the development of transition programs or transitional care. And this is really very helpful to know how to do this. So, second box, feasibility and piloting, testing procedures, estimating recruitment and retention, determining sample size. If this were a research class, then I would go into the details of this, but I will skip this for now because this is the traditional things you have to do when setting up a study. But this goes beyond the purpose of this presentation. Then evaluation. There we see assessing effectiveness, understanding change processes, and assessing the cost effectiveness. Remember again the pyramid, the review of Deborah Hilderson, no level 1 evidence. I said times have changed in the meantime. And indeed, early 2016, a Cochrane review came out. In this Cochrane review, 4 controlled trials were included. These studies were conducted in spina bifida, congenital heart disease, diabetes, and in a mix of chronic conditions. The follow-up periods ranged from 4 to 12 months, and in general, the sample sizes were small. Overall, combined 238 patients. So this is really small. And different outcome measures were used. What are the conclusions of this Cochrane review? Since few studies were eligible for this review, and this has to do with a very stringent procedure and method that Cochrane is using, the overall certainty of the body of evidence is low. No firm conclusions can be drawn about the effectiveness of evaluated interventions. Further research is very likely to have an important impact on our confidence in the intervention effect and likely could change our conclusions. What these authors are saying, please continue doing effectiveness research because this is what we need. Right now we cannot draw any firm conclusion. Of course, this is a Cochrane review with very stringent criteria, as I just said. This is not the only review article that has been published so far. Some years before, in 2012, this review has been published, Improving the Transition Between Pediatric and Adult Healthcare, a Systematic Review. In this review, 10 pre, post, and comparative studies have been included. So they were not looking only at level 1 evidence. Level 2 evidence was sufficient enough to be included. 8 of the studies included were conducted in diabetes, 1 in cystic fibrosis, and 1 in organ transplantation. Again, small sample sizes, 50 to 100 in the studies. And intermediate outcomes were used, like hemoglobin, A1C, the proportion of missed appointments. Again, it's understandable. You cannot take the most distal outcomes because then you will never be able to show any effect whatsoever. So you need to go to more proximal, and the price to pay is that these factors are intermediate, or these outcomes are intermediate. What are the conclusions of this review? Patient education programs and joint pediatric adult clinics as services can improve, not do improve, but can improve outcomes following transition to adult care in patients with type 1 diabetes. This is, however, not generalizable to other conditions. Also, this review shows that there still is a gap and a need for doing research. And if you identify a need as a researcher, you also feel the need to do something about that. This is the reason why we started the Stepstones project. Stepstones stand for Swedish Transition Effects Project, supporting teenagers with chronic medical conditions. Again, we aim a generic approach, but again, for different reasons of accessibility, network, and so on, we start with congenital heart disease. The funny thing, the challenging thing when we were designing this study was our concern about contamination of control groups. Remember, this is a complex intervention. When you are doing certain things in an intervention group and you're using a plain randomized control trial, maybe people that are caring for patients in the control group may look, oh, what is going on there? Ah, a nurse is talking to the patient. Yeah, maybe I should talk a bit more with my patient. And they are implementing things that are no longer usual care, and it's contaminating the control group. How to deal with this? We came with this solution. We call it a hybrid experimental design. So we still have a randomized control trial. So we are doing this study in 4 centers in Sweden. 2 centers have been assigned as randomized control centers, and in these centers they are randomizing at patient level. So it's a web-based system that is saying, okay, this patient intervention group, this patient intervention group, this patient comparison group, and so on. But then we have 2 other centers, and we call them the intervention naive centers. There are no interventions going on there, just the usual care. And therefore, we assume that the risk for contamination is lower than in the intervention centers. This is an elegant way to control for potential contamination when studying a complex intervention. The primary outcome in this study is patient empowerment. Again, think about distal and proximal outcomes. If you go into the concept of empowerment, then you learn that people that are empowered are better capable of navigating in the system, better capable of taking care of themselves, higher self-management skills, and so on and so on. So if we can work on this empowerment, in turn we will have secondary benefits, and sometimes in the longer term. So this is the effectiveness study that we are doing within Stepstones, and this is, like you see in the box of the complex intervention scheme, assessing the effectiveness is an important thing. But it's also important to understand the change processes. So we are also doing a process evaluation in that study. This comprises feasibility, and feasibility has to do with, is this acceptable for patients? Do patients want to come to the hospital to have this transition care intervention? We will look at adherence and fidelity. Are the transition coordinators doing what they are assumed to do, what they are trained for to do? What about attrition? Are people saying after a while, oh gosh, I'm tired with this, I will stop? Because later on it's important to know how many patients quit from this. And safety. It is very unlikely that there are safety problems with interventions like this, but we need to be prepared. We need to have forms on which we can report safety issues if there would be. Then the mechanism of impact, we want to interview transition coordinators, patients and parents to understand, like, how comes that this is working? What was most striking to you? What was most effective according to your experience? And maybe certain ingredients of the interventions were not recognized by patients and parents at all. So then it's unlikely that these were the active ingredients. If it is all about the transition coordinator, yeah, then you know this is the key. Yeah. So the mechanism of impact will come up from there. And then the possibility for permanent implementation. Process evaluation always has the objective to facilitate permanent implementation after the study has been done. So you can set up a brilliant study, but you need to involve the key stakeholders, because otherwise they will not buy this. And maybe you have developed a nice intervention that would not work in their intervention, in their setting, in their context. The problem here is the conflict between, on one hand, having a well-controlled study where you want to avoid contamination as much as possible. So we cannot inform all the teams about what we are doing. That would be perfect for having a good buy-in, but it would be detrimental for contamination. Yeah. So what we do right now is we keep them, well, they are informed, they know what is going on, and they know that they will not get more information than we give, and they know why. But at the end of the project, then we will buy them in. And then we will say, okay, this is what has been done, this is what we learned, this worked, this didn't work. If you think about permanent implementation in your setting, in your context, with your possibilities, your capacity, the resources that you have, how do you look upon that? So that we kind of at the end can change or adapt the intervention if needed, but we still did not jeopardize the randomized control trial. And then here, assessing the cost effectiveness, yes indeed, that's what we also want to do in this study. An economic evaluation in which we on one hand will investigate the cost effectiveness of the study and also a budget impact analysis. Imagine that this study is effective, that the intervention is effective, and we go to the Swedish Ministry of Health and we say, well, here is the evidence, you have to invest in this. Then they will have the question, the first question will be, how much will this cost? If you want to do this for all people with congenital heart disease in Sweden, on one hand, and imagine that we want to expand this to other conditions, what would be the impact on our budget? Well, this is what we do in the budget impact analysis. Overall, 2 PhD students are working on this project. One on the effectiveness study and another, and the recruitment is ongoing at this moment, someone who is doing the process evaluation and economic evaluation. And then the implementation. Again, I will not go into the details because you could understand there is still a lot of work to do before we really can think implementation without any problem, permanent integration into the usual care. We are not there yet, but a lot can be done on beforehand, and it's again like Annaloes said in the session this morning, don't wait until all the research have been done, because research never will be done, never will end. So you can already do something, pick the low-hanging fruit. Okay, I'm coming closer to the end of this presentation, and then I have to go back, of course, to the aim of it, where to go from here. And we were talking about transition and transfer. What are the things, if you ask me what we need to do, what should be the priorities in the upcoming years, maybe even decades? We should come to a uniform definition and operationalization of the different concepts of discontinuation of care. It would really be instrumental for researchers, but also for clinicians, to have a kind of taxonomy that we all know what we are talking about when we are using the term loss to follow-up. Second, we should implement interventions that reduce care gaps and eventually loss to follow-up. Okay? Remember the risk factors, remember the preventative factors. You can already do something about it. And some of these interventions, low cost, easy implementable, start with that. These are the quick wins. And third, we need to undertake, and this is a message for the researchers, we need to undertake multi-level studies to identify risk factors beyond the patient level. So including hospital level and including healthcare system level. What about transition? Use the evidence base to build transition theories. There is a lot of evidence, but as long as we do not bring this evidence together into meaningful insights, it's still fragmented information. And for people working in day-to-day clinical practice, it's utmost difficult to navigate through the plethora of this evidence. So if we are able to bring this together to a sound understanding of what transition is all about, this would be really, really helpful. Use of intervention mapping methodology to develop and describe transition programs. As I indicated before, this methodology has not been applied in the development of transition programs so far. But if we would be able to do so, we may certainly identify specific gaps in the interventions of which we did not think until then. And then investigate effects, processes and cost of transition programs using sound research methods. So aim for the highest level of evidence, and it's not because 4 controlled studies have been published so far that there is no need for more studies. The Cochrane review indeed indicated we need more studies, more effectiveness studies, to be able to draw firm conclusions. So this is the end of my presentation. Thank you so very much.